Good evening, everyone. Hi. Hi, Dr. Yvonne. And good morning to you. Good morning to the audiences from the US. And welcome to the 7th Mahidol Johns Hopkins NCD's Research Collaborative Center webinar in the topic of cardiovascular disease management in low and middle income countries. I'm Dr. Rungna Parushop, or Luna. I'm delighted to be a moderator for today's event again. And now I would like to say that the topic today is very interesting in hypertension management and stroke management in low and middle income countries. So today we have 4 speakers whose expertise on cardiovascular disease management in low and middle income countries. For today, we will start with the first presentation for 40 minutes, then following by the second presentation for about 20 minutes. And we will have the Q&A and discussion at the end. Please feel free to send your questions in the chat box. So now I would like to introduce the first 3 speakers who are going to present in the topic of hypertension management. So please let me introduce the first speaker, Associate Professor Dr. Ivan Commodore Mensah. Dr. Ivan is an Associate Professor at the Johns Hopkins School of Nursing and the Department of Epidemiology at the Johns Hopkins Bloomberg School of Public Health. She is also faculty at the Johns Hopkins Center of Health Equity. She is a fellow and board member of the Preventive Cardiovascular Nurses Association. As a nurse scientist and cardiovascular disease epidemiologist, her program of research seeks to reduce disparities in cardiovascular health among African descent populations locally and globally, specifically in sub-Saharan Africa, through epidemiological and community engaged methods. She is the co-PI of the Addressing Hypertension Care in Africa at HINCRA, at HINCRA study, cluster randomized control trial testing the effectiveness of a nurse-led mobile health intervention to improve hypertension control in Ghana using an implementation science approach. She is a fellow of the American Academy of Nursing and American Heart Association, or AHA, and a member of the steering committee of the National Hypertension Control Roundtable. She serves on the advisory board of the National Hypertension Control Initiative and Target BP. Lastly, she is a board member of the American Heart Association, Baltimore and Greater Maryland area. Please welcome Dr. Ivan. Hi. And the second speaker is Samuel Brinkero. Did I pronounce your last name correctly? Okay, I apologize if I pronounce incorrectly. So Samuel is the PhD candidate and research assistant at the Johns Hopkins School of Nursing. He earned his Bachelor of Science in Nursing from the University of Rwanda and a Master of Science in Global Health Delivery from the University of Global Health Equity in Rwanda. Samuel's research interests are cardiovascular health outcomes, health systems strengthening through quality improvement, and community engagement in research. Hi, Samuel. Hi. And the third speaker is Thomas Hine. Thomas is a public health practitioner and senior officer of the Ghana Health Service. Thomas holds a Bachelor of Science degree in nursing from the Kwame Nkrumah University. Is that correct? Okay. The University of Science and Technology, Ghana. He has worked in different capacities in over 5 different health facilities in Ghana. He has held a number of leadership and managerial positions, including head of outpatient department, deputy nurse manager, quality assurance coordinator, and district chairman of Ghana, Registered Nurses and Midwives Association, among others. During this period, Thomas led the establishment of hypertension and diabetes clinic in a district hospital to improve hypertension care. He has facilitated several training for healthcare providers involved in hypertension care in Ghana. Additionally, Thomas is a director and co-founder of an NGO, High Foundation, conducting community screening and awareness for hypertension and diabetes in rural communities in Ghana. Thomas holds a Master Science degree in International Health from Heidelberg University under a development-related program funding from the DAD Scholarship Scheme, Germany. Thomas was also awarded a Commonwealth Scholarship in 2020 to pursue an MSc in nursing at the University of Dundee, UK. In 2020, Thomas won a €12,000 project grant from the Pharmacists Without Borders, PSF Germany, to build the capacity of over 100 healthcare professionals in 4 district hospitals in Ghana. He is an early career cardiovascular researcher with field publication and a reviewer for the International Health Journal. He currently works with the 10 District Hospital Ghana as head of public health unit. So please welcome the first 3 speakers. And without further ado, could you start your presentation in the topic of hypertension management, please? Thank you.
Thank you so much, Dr. Rushab, for that lovely introduction. I'm Yvonne Commodore Mensah. I'm here with Samuel and Thomas, who will reintroduce themselves when they present shortly. We are so honored to have the opportunity to present on the topic patient, provider, and health system level determinants of hypertension outcomes in sub-Saharan Africa. Although the scope of our presentation is sub-Saharan Africa, I think we would argue that a lot of the things we're going to talk about apply to different low and middle income country contexts. Next slide. So our learning objectives are as follows. First, we'll talk about patient-level determinants of hypertension outcomes in sub-Saharan Africa. We'll talk about provider-level determinants of hypertension outcomes. And lastly, we'll talk about health system-level determinants. I'll discuss patient-level determinants. I'll hand over to Thomas, who will discuss provider-level determinants, and Samuel will talk about health system-level determinants of hypertension outcomes. Next slide. So to frame our conversation, it's important to discuss the global burden of hypertension. We know that globally about 1.4 billion adults have hypertension, but unfortunately we know that 2/3 of the patients with hypertension reside in low and middle income countries. And what you can see from this graph is that although the burden of hypertension is high globally, the burden is not even. And there are regions globally that have a higher burden of hypertension than others, particularly sub-Saharan Africa and several Asian countries have a higher burden of hypertension than other regions globally. Next slide. It is approximated that in sub-Saharan Africa, approximately 130 million people have hypertension. And in hypertension research, we have what we call the rule of house, right? Where half of the people are diagnosed, half are treated, and half are controlled. But unfortunately, only 41% of people who have hypertension are aware. Also, only 25% of the people who are aware of their condition are being treated, only a quarter. And among those who are being treated, only 11% have controlled blood pressure. Why is this important? We know that hypertension is a major risk factor for cardiovascular disease, stroke, kidney disease, and the next presenter, Susan, later will talk about stroke. Next slide. So in Ghana, what do we know about the burden of hypertension? Dr. Bosu conducted a systematic review and meta-analysis recently, which was published last year in PLOS One. And in that meta-analysis and systematic review, they found that the pooled prevalence of hypertension was 27%. And again, thinking about the rule of house, only 35% of people who had hypertension were aware of their condition. Only 22% were being treated, and only 6% of those who were treated achieved controlled blood pressure, defined as 140/90 or less. An important finding in that review was that the prevalence was similar by sex and also by rural and urban residents. There's been some literature that suggests that the burden of hypertension is higher in urban areas, but in this review, they found that also in rural areas, the burden of hypertension was rather high. In this review, they also found that there were very few studies that were conducted in specific regions of the country. Most of the studies were conducted in the southern region of Ghana, as indicated by the blue color, right? So 32 studies were conducted in the Greater Accra region, 20 in the Ashanti region. But unfortunately, when you look at Bono East and the Bono region, very few studies have been conducted. So we really don't have a good sense or a true sense of the burden of hypertension in Ghana. Next slide. So I mentioned earlier that hypertension is a major risk factor for stroke. And what do we know about stroke in West Africans? So Dr. Fred Sarpo and colleagues conducted the SIREN study, which was a multi-center case control study involving 15 sites in Ghana and Nigeria, and there were 2,118 stroke cases. One of the important findings in this study was that almost a quarter of the cases were among adults who were less than 50 years old. And in contrast, in higher income countries, the burden of stroke is higher in older adults, 60 and higher and older. Another finding was that there was a striking preponderance for hemorrhagic stroke versus ischemic stroke. So 52.5% of the cases of stroke were hemorrhagic in nature. And when you compare that to, for instance, the US, 13% of stroke cases are hemorrhagic in nature. And they also wanted to understand the causal risk factors that were associated with hemorrhagic stroke, and hypertension was implicated in 92% of the cases. So hypertension was the causal risk factor in 92%, almost 92% of the hemorrhagic stroke cases. And they also examined modifiable risk factors that were associated with stroke in general. And again, hypertension was the major risk factor at 89%. Next slide. So how do we explain the high burden and what accounts for the high burden of hypertension but low blood pressure control in sub-Saharan Africa? As you can imagine, there are multi-level factors that are associated with low blood pressure control. But for the purpose of this presentation, we are going to focus on three main areas. So there are individual or patient-level factors that are associated with blood pressure control. There are also provider or team-level factors that are associated with blood pressure control. There are local and community-level factors. We're not going to discuss that in too much depth, but there are also systems-level factors that are associated with blood pressure control. And in the interest of time, we will focus on those three main levels. Next slide. Now let's talk about patient-level determinants. As I alluded to earlier, patient-level and community-level determinants are associated with blood pressure control. So family history, having a history of hypertension, family history of hypertension is associated with a higher risk of developing hypertension in later life. Older age, comorbidities, people who have hypertension and diabetes are less likely to achieve blood pressure control. Unhealthy lifestyle, so thinking about a diet, physical activity, and then poor adherence to medications. These are all patient-level factors that are associated with blood pressure control. However, recently there's greater appreciation that these, what we're calling patient and individual level factors, are really determined by social determinants of health, right? These are the conditions in which people live, learn, play, work, and pray that are associated with health outcomes. So they include education, the social and community context, where someone resides, their access to quality healthcare, and economic stability. These are all factors that contribute to poor blood pressure control. Next slide. So Dr. Stoffel and colleagues wanted to understand what are the determinants of blood pressure control in Ghana, and they conducted a multi-center hospital-based study among 2,632 participants with hypertension and or diabetes. So they had to have hypertension, and some had hypertension and diabetes. And they examined factors that were associated with uncontrolled hypertension, defined as greater than or equal to 140/90. And we found that male gender was associated with a higher odds of having uncontrolled hypertension. Secondary education versus no education at all was associated with a higher odds of uncontrolled hypertension. And non-adherence to antihypertensive treatment was also associated with a higher odds of uncontrolled hypertension. And those who had a lower intake of fruits had a higher odds of uncontrolled hypertension. And there were other clinical factors that were associated with poor blood pressure control, including the number of medications that were taken, as well as kidney function. Next slide. In a separate study that was examined adherence to hypertension medications, they found that there were disparities in adherence by specific low and middle income countries. So the study was focused on the sub-Saharan African region, and they found that in particular countries, the prevalence of low adherence was high, such as low income countries, including Benin, Mozambique, the DRC. These were countries that had a high prevalence of low adherence to therapy. But it's also important to acknowledge that when we talk about patient adherence, there are other factors that contribute to patient adherence, including provider and health system level factors. And they also wanted to understand what the main reasons were for non-adherence to therapy. And in about a third of participants, they noted that forgetfulness was the main reason. But in 26% of the participants, the high cost of treatment was the main reason that patients were not taking their medications. And so when we think about adherence, we shouldn't always blame the patients, but also understand that there are reasons why patients are not adherent to their therapy. And these social determinants that we discussed earlier contribute to non-adherence. Next slide. And now I'll hand over to Thomas, who will discuss provider level determinants of hypertension care. Thomas?
Okay, Prof, thank you. And hi to everyone from Ghana. and thank you for the opportunity to participate in this webinar. As Prof said, I'll zoom into the provider level determinants of hypertension. Yeah. Next slide. Good. So the first element we want to talk about is the inadequate number of healthcare providers in low-middle income countries, which has really been a challenge in the implementation of many interventions. And we tried to highlight this study conducted in 2021, where they used data from the WHO observatory data set, as well as the World Bank 2018 population estimate. And in this graph, or let's look at the map, you can see the density of physicians in high-income countries, which is a bit greater than 30 per 10,000 population. And it goes down to low-middle income countries where you can see 3.5 per 10,000 population. Now, it is worth to mention that this study actually included 172 countries across the globe. And out of that, you have 51 from high-income countries, you have 51 from upper-middle income countries, but 28 from low-income countries, as well as 42 from low-middle income countries. And that sort of gives us an idea about the limitation of data in terms of hypertension care. Now, when you look at the graph critically, you realize that low-middle income countries actually has a wide gap when it comes to hypertension care. What they actually did was to estimate that if a patient attend clinics at least 3 times in a year, will the number of physicians in our countries be able to meet the demand of such patients? And so when you look at it from low-middle income countries, you realize that 89% of the countries had gaps when it comes to the patient demand. When you look at lower middle income countries, you realize that you have a gap around a little over 69%. So 69% of countries will not be able to provide services for their patients if the patients are attending 3 times clinical care in a year. But when you look at upper middle income countries, it's a little around 20% gap, and high income countries, just a little over 2%. But this is also informed by the physician density, where you have a lot of physicians in developed countries, but then in Africa and sub-Saharan Africa, you have very limited number of healthcare professionals or physicians, to be very specific. And this study actually highlights the need for task shifting, because given the number of physicians we have in Africa, we will not be able to meet the demand of our patients if we are to say that health services for hypertension care should solely be provided by physicians. Let's go to the next slide. Now, another critical element or determinant of hypertension control is an opportunity for training our healthcare providers. And like I've said in many other platforms, infectious diseases have dominated our healthcare focus. And so non-communicable diseases hardly get the opportunity for professionals to be trained. And you have situations where professionals have worked in hypertension clinics on NCDs, consider it to be cancer and the others, and have never been trained. And I always use myself as an example, someone working in a rural district hospital in Ghana. I've led an establishment of a hypertension clinic, and for 5 years, I never had an opportunity to attend clinic. But it is also important to state that training opportunities actually inform awareness and knowledge. It is only through training that our healthcare professionals will have the opportunity to learn what is in the treatment guideline, if they exist. And when you look at this code from one of the studies we have included to support what I'm trying to say, the provider says that I haven't had a refresher training on NCDs, and the training in the training schools don't cover these diseases. And this is also very true, because it was until 2013 actually, that the University of Ghana actually integrated NCD as part of the models for an MPH program. So this highlights the limited opportunity that our providers have when it comes to hypertension care. And it goes on to affect hypertension control. And this applies to other sub-Saharan Africa like Zimbabwe and Rwanda, where most of the healthcare professionals equally have very limited knowledge about hypertension, have very limited knowledge about whatever is in their treatment guideline, even if they exist. Let's go to the next slide. Now, another important element which I always allude to as a professional is the communication between providers and patients. The goal for hypertension treatment is to achieve an optimal target, and so the only way we can build the confidence of our patients is to give them the opportunity to access relevant information which they can apply. And in this study, which was conducted also in Ghana, one of the healthcare professionals articulated that we find it difficult explaining it in our local language. What is BP in our language? What will we say? Your blood is going up. This blood that flows in the veins. So you realize that even at the healthcare provider level, they need to really understand how it is to, communicate the key message about hypertension to the patient. And it is also important to emphasize that medication adherence, self-care efficacy, and reduction in complications are all well interwoven within provider-patient communication that is effective and collaborative. And let's go to the next slide, where I try to break down the various components of patient-centered communication and what patients actually expect from healthcare providers. And in this study, they try to look at it from a biopsychosocial perspective, where patients expect that the communication between the provider and the patient should be a knowledge kind of exchange, not generalized risk across patient groups, try to treat the patient as a person, try to understand the patient's sort of characteristics. And I always say that, many times patients are happy after clinic appointment only when you have engaged them adequately. And that is the only way they can also, recommend your clinic to other people. Yes, the drugs may be there. They may not even spend so much time at the consulting, but when you engage them adequately, they are very happy. And it is important to also emphasize that active engagement is good for therapeutic processes. And when you look at the patient outcome, they go home very satisfied. There is reduction in anxiety. There is an improvement in decision sharing, which is also critical to hypertension control. And I must say there is a bit of anxiety because in some part of sub-Saharan Africa, if somebody is diagnosed with hypertension, they have no idea what to expect. Sometimes they want to hide it from society. Sometimes it is being seen as diseases of, spiritual, paradigms and all that. So it is only when we're able to engage them that will build their confidence. They understand what we want them to do, and they become part of the care process. They become active participants and not just spectators or objects who are being treated. Next slide. Good. Another important element that actually affects hypertension control is therapeutic, inertia. When I talk about therapeutic inertia, it is the failure of healthcare professionals, here providers, to escalate or increase treatment when goals for hypertension treatment has not been achieved. And specifically speaking, we are talking about BP targets. So if a patient has a BP of 150, 100, you want to bring it down something below 140, 90. But the reality is that most healthcare providers are unable to do that. And there are several reasons why we are unable to do that. And Ohishi tells us a new weapon for fighting hypertension paradox. And in a small diagram you see here, you have what we call the bad inertia. That is when the physician says, oh, let's just wait and see. Maybe your blood pressure might go down on its own. The physician says, the patient says, okay, I agree. But when you talk about good inertia, the physician wants to take further actions to ensure that the drugs are working. So he says, let's change your medication and see. And the patient says, okay, that is okay. So you have that sort of collaborative communication, like I said, also here. But let's zoom in into Ogede et al., who came up with some reasons why therapeutic inertia might happen in Africa. And one of the reasons he gave was the fact that many times some physicians think that they are over, estimation of the care they provide. And it is really the case, especially when you have given everything you have to the patient and yet the blood pressure still remains the same. Sometimes you're frustrated. And this also explains the limited training opportunities that I did indicate earlier. If people are not aware of what the standard says, what is specified in the treatment guideline, they are unable to explore other options to treat the patient. And another reason, which he called soft reasons, is the fact that sometimes you're so stressed in the consulting room, so you'll be saying, okay, let's wait for next visit. Okay, let's wait and see if things might change in the next month or two. These are some of the practicalities that happens on the ground, and I encounter some of these things on daily basis. Sometimes when you look at the load outside and consider the time that you might want to spend with a patient, you might not finish the day. So you are likely to use some of these soft reasons to excuse yourself, and that doesn't really contribute to achieving optimal blood pressure control. So, like I've said, and this came shortly from WHO, who said that the barriers to hypertension care are more of health system, and when I say health system, I mean provider level specific than the patients themselves. So this means that when we improve the competency, the confidence of our healthcare providers, and we improve the health system itself, our patients are ready to comply. They are ready to do what we ask them to do, and we will be able to achieve the WHO target of reducing cardiovascular deaths by 2025. Let's go to the next slide. So at this point, I'll leave it over to Samuel to continue from there. Thank you.
Thank you, Thomas. And thank you everyone for this opportunity for me to take part in this webinar and talk about the health system level determinants of hypertension care. This is what I'm going to be talking about. When I talk about the health system determinants of hypertension care, I often think about it as the 5 S's. This is the system that we used to use at Partners in Health. I worked at Partners in Health for 2.5 years, and they also use this system of the 5 S's, which is the staff, space, systems, and social support, to discuss the health system factors that affect the delivery of any health care service. And the staff involves having sufficient number of well-trained healthcare providers providing a certain health service, and in this case, providing hypertension care. And Thomas has talked more about this. And the staff is about the availability of tools, equipment, consumables necessary for the care provision and care coordination. And the space is about the accessibility of healthcare facilities capable to handle the patient load with acceptable wait time. And the system is about the leadership, governance, information systems, and also financing. We will talk about some of those things, and social support as well. It's very important because there are people who require that in order to achieve the desired health outcomes. In the interest of time, I'll talk about some of these things, but we will engage in a discussion later and we can talk more about this. Now, when we talk about hypertension care, we know some things. We know that there is a high rate of uncontrolled hypertension in sub-Saharan Africa. Dr. Commodore Mensah has mentioned that approximately 10% of patients with hypertension do not have it under control in sub-Saharan Africa. And we also know that there is guidelines for hypertension management, and there are different guidelines by high-income countries, by international hypertension societies, but also by different countries in sub-Saharan Africa, which have taken an approach of adopting those guidelines developed in high-income countries and adopted them to their local context. Yet, we continue to see despairing outcomes on hypertension care, and the quality of life of patients with hypertension remain low. And what is the problem? We find that the gap is, of course, in the implementation of the guidelines. And what's that problem? Usually when there is a poor implementation of the guidelines and putting evidence into action, there's usually the lack of transdisciplinary research, the understanding that there will be a need for collaboration between different disciplines, and also the engagement of those people who will be participating in putting into effect those guidelines. For example, the healthcare providers and the patients. You may understand that patients and healthcare providers in low and middle income countries usually do not get ability to participate in those studies. And also the dissemination and translation of those initiatives in these underdeveloped areas. And also when the approaches are effective, what are the approaches which are taken to make them sustainable through local capacity building? Those are some of the problems that we see, which lead to the gap between the evidence that we see and the health outcomes that we see in hypertension management. Now, when we talk about this though, before we even go to the implementation, we will wonder, before we get there, how are health facilities in low and middle income countries, specifically in sub-Saharan Africa, how are they ready to provide hypertension service? Now, my dissertation is on exploring the health system factors of hypertension care in sub-Saharan Africa, and I've recently traveled to Ghana actually to conduct my study. I have got the opportunity to interact with the healthcare providers and health facility leaders in different health facilities in Kumasi, Ghana. And during my familiarization with this topic, I have realized that in Nigeria, for example, Orji and colleagues conducted a study in 60 health facilities, and these were mostly primary healthcare facilities. And when they surveyed those health facilities, only 15% of the facilities had at least one healthcare provider who's trained to manage hypertension. And Thomas has talked more about this. And only 13% of those facilities had hypertension treatment guidelines available in the facility. And only 41% of the facility had at least one antihypertensive medication available. And you may wonder what happens to the remaining 59% health facilities. When a patient goes there and the medications are not available, the healthcare provider will try to their best ability to prescribe their medication if needed. And when they prescribe their medication, the patient will take their prescription. And many times the health insurance that they have will not cover the medication at the private pharmacies. And now they have two options. They will be wondering, should I use this last penny that I have to purchase the medications, or should I use it to purchase food for my family? And that is a tough call to make. And in Ghana, I invited 15 health facilities, which were mostly at the secondary level of healthcare provision, not primary facilities, but more secondary. And 67% of the 75 healthcare providers who responded to the survey said that they had received training on hypertension care. But you have to understand that 70% of those who said they had received training, they were referring to the on-job orientation or on-job training. And also 80% of the facilities reported that they have the guidelines, and the guidelines were available, we could see them. But when we asked them about the algorithm, which is in the guideline about hypertension management, many of them were not aware of that guideline, which means it is a big booklet, which is usually in the drawer, but referring to it for managing patients with hypertension is not common practice. And the antihypertensive medications were available 78% on the rate of 78%. But here you have to remember that here we were serving the secondary level health facilities. And when we're serving them, we are referring to these basic medication, the angiotensin converting enzyme inhibitors, the thiazides, and the beta blockers, calcium channel blockers. But since these facilities manage patients with even complicated hypertension, they need to also have the second line medication for management of hypertension. And those medications were mostly unavailable. And when we also talk about hypertension management or system level, we talk about the space, which is the health facilities, accessibility of health facilities. Now, Jetster and colleagues in 2020 mapped the physical access to health facilities in sub-Saharan Africa by older adults. By the way, I have to mention that older adults are the ones who are likely to have hypertension. And 9.6% of those older adults had to travel 6 hours longer to a nearest health facility, to a nearest hospital in sub-Saharan Africa. And this is an average. But this gets worse in Sudan, where 41% of older adults have to travel 6 hours or longer to a nearest hospital. And 16% of the older adults had to travel 2 hours or longer to any type of the health facility near them. And this also gets worse in Sudan, for example, where 54% of older adults have to travel 2 hours or longer to any type of health facility near them. Now, you may wonder, does spatial accessibility of, excuse me? Okay, yeah, does spatial accessibility of affect hypertension outcomes? Yes, it does. A study conducted by Ambao and colleagues showed that 30 minutes or shorter travel to a health facility is associated with twofold likelihood of achievement of blood pressure control. And this study was conducted in Ethiopia. Now, when we were doing data collection in Ghana and exploring the health system determinants of hypertension care there, we realized that there is lack of guidance on hypertension care at the community clinics, which means that the care for hypertension in Ghana is mostly centralized to hospitals, again, requiring people to travel long distances to get care for hypertension. Now, the non-communicable disease risk factor collaboration has put together some of the guidance on how we can manage patients at different levels. We have seen from Dr. Commodore Mensah that there are patients who are diagnosed, of course, a small percentage, and of those who are diagnosed, some of them are treated, but even those who are treated, only a handful of them achieve blood pressure control. Now, at the big level of patients, there will need to be a public health intervention for hypertension prevention. And this could be like national-wide policies, for example, salt reduction, mass sport policy. I'm from Rwanda, and Rwanda has put up a policy which is really wonderful, where on every last Saturday of the month, there is a car-free day where people are given time to engage in physical activities, and they're actually encouraged to do that. And people receive text messages on their phone encouraging them to engage in physical activities. Something like those could be applied at the higher level. But now there are people who are not diagnosed. What are some of the interventions which could help? Universal health coverage, because I've seen that higher out-of-pocket spending or high cost of care is associated with non-achievement, not even receiving care for hypertension. So universal health coverage, effective screening, clinical guidelines for the screening patients, and also the task sharing among physician and non-physician healthcare workers. And now, how about the people who are diagnosed but are not treated? Some interventions can also help. Again, universal health coverage, clinical guidelines, and innovations to improve adherence and treatment efficacy, but also task shifting. And the people who are treated but do not achieve blood pressure control, there are also some guidance which could help. For example, the clinical guidelines, which are tailored to the local context of the countries, the different innovations to improve adherence to hypertension care, such as the poly peer, where different combination of peers are put into one peer, and telemonitoring, where you are now monitoring patients, not necessarily for them to travel to the health facility, but you could use the telehealth. But also the task sharing, where you do not require physicians to be the ones who see the patients, but non-physician healthcare workers are trained to manage patients with hypertension. Now, I would be remiss if I did not mention the heart pillars of hypertension care. Heart is the technical package by the World Health Organization, and it mentions the different steps that can be taken to manage patients with hypertension. And here I will just mention one, which is the risk-based cardiovascular disease management. And these approaches recommends to see patients with hypertension not only on the list of hypertension, but on the bigger picture of cardiovascular disease management. And this recommends looking at this patient, considering where do they live, what's their age, what is sex, those different risk areas, behavioral factors such as the smoking, comorbidities such as diabetes and chronic kidney diseases. Of course, there's historic blood pressure and cholesterol measurement if it is available. And the systems for monitoring also is very important. For example, data recording are using that data in order to continuously improve the quality of care. Now, we could talk more about this, but for the interest of time, there could be policy implications. According to the discussion we have, it looks like minimizing out-of-pocket spending through health insurance could help patients achieve better treatment for hypertension care. And also promoting team-based care and contemplating task sharing and task shifting. This task shifting strategy for hypertension care control is a randomized control trial, which is actually being conducted in Ghana, same as Adinkra, Adinkra happens to be a parent study for my dissertation project. And both studies are continuously demonstrating that task shifting and task sharing are effective in management of patients with hypertension. And of course, this builds up on the additional evidence which have shown that team-based care and task sharing and task shifting are effective management of patients with hypertension. Again, decentralizing hypertension care to close to the community will also be important. And the context-specific treatment guidelines are necessary. There's a study which was conducted recently, and it has shown that only 25% of countries in sub-Saharan Africa have hypertension guidelines which are tailored to their local context. Again, this speaks to the need of having these treatment guidelines available. And also engaging other sectors, not only health system sector, but also agriculture, economic empowerment, sports. All the involvement of other sector helps to make sure that patients achieve better blood pressure treatment and better outcomes. Now, I will call Dr. Commodore Mensah to help us tie all of this together. Dr. Commodore Mensah.
Thank you. Yes, thank you so much, Thomas, and thank you so much, Samuel, for highlighting the provider and system level determinants of hypertension control. So to wrap things up, we just want to emphasize that in terms of addressing the patient level determinants, we need to assess and address medication adherence, for instance, and understand the reasons why patients are not adherent to their therapy. If they cannot afford it, we need to explore opportunities to provide affordable medications to improve blood pressure control. We also need to invest in training and building the capacity of healthcare providers. Thomas talked about training, right? So when we think about global health funding, we should also consider non-communicable diseases. In addition to communicable diseases, we know that there's a mismatch in terms of funding that's available to train and build a capacity of healthcare providers in the space of non-communicable diseases. We also need to ensure that there's universal health coverage, and this is something that WHO has advocated for, and we need to ensure that all countries in the sub-Saharan Africa adopt this approach. We also need to strengthen health systems to overcome these challenges and barriers that we've talked about. And lastly, I just want to emphasize the importance of implementation science. So Samuel talked about the quality gap. We know that there are evidence-based strategies, including team-based care, interventions to improve medication adherence. But the gap really is how to implement these in low and middle income countries. And that's where implementation science comes to play. And so in conclusion, we want to thank you all for your time and attention. I think we'll take questions after Subsan presents. Thank you so much.
Thank you very much for all speakers, Dr. Commodore Mensah, Thomas, and Samuel. And thank you for the wonderful presentation and conclusion. So right now we know that there are so many factors that lead to the low hypertension control that you have mentioned, for example, like social determinants of health, provider level determinants, and also like the bigger, like major factors such as the policies and assistance levels. So the questions, we will move to the discussion later on, but please feel free to type the questions if you have any questions right now. So the next presentation would be the stroke management. As the first three speakers have mentioned already, right, that hypertension is leading to stroke, especially hemorrhagic stroke. So Subsan, hi. He's here with us already, so he's going to present about stroke management. But first, let me introduce the last speaker. Subsan is the last speaker, and he is a lecturer at the Department of Medical Nursing, Faculty of Nursing, Mahidol University. And right now he's a PhD student at Case Western Reserve University, USA. His research interests include self-management and medication adherence in patients with chronic diseases, particularly patients with stroke. And right now, Subsan, can you please start your presentation? Thank you.
Okay, can you hear me?
Yes.
Okay, thank you so much, Dr. Rungnapha, for the introduction. And thank you, Dr. Iwan, Thomas, and Samil for a great presentation. So, okay, let me start now. So I would like to do the presentation in the topic self-management in stroke population in low middle income country and Thailand. So as you know, stroke is a leading cause of mortality and disability. Stroke was the second leading cause of global disability adjusted life year, which is increased from 1990. In 2016, the statistics show that 13.7 million people experienced their first stroke. Interestingly, 2.7 million died due to ischemic stroke, whereas 2.8 million people died due to the hemorrhagic stroke. As we see in this figure, you can see that the countries such as China, Russia have the highest incident of stroke per 100,000 people, and also Thailand and others low middle income country, the age standard stroke incident by country for both sex in 2016 show that the incident is around 150 to 200 per 100,000 people. How about stroke situation in low middle income countries? According to the study named Stroke Interstroke study, the people in low middle income country experiences more serious stroke, poorer access to healthcare, and fewer investigation and treatment than the people in high income country. Moreover, any future rise in stroke rate will most likely be driven by low middle income country. This problem including poor public awareness about stroke warning sign, inadequate of the preparedness of acute stroke care, rehabilitation, and community support are obvious in low middle income country. So the stroke situation is almost the same as the hypertension situation that the previous presenter has mentioned before, especially about the poor public awareness and also the community support. How about the stroke epidemiology in Thailand? There was an increasing rate of the people aged more than and equal to 15 years old admitting in the hospital in Thailand due to stroke from approximately 184 to 219 per 100,000 population between 2017 and 2021. But the 30 days mortality rate from stroke in Thailand a little bit declined from 9.9 to 9.3 in 2017 to 2021. So this could result from the increasing rate of the stroke patient who receiving the anticoagulant treatment over the past few years. So the study from my colleague and I showed that 43% of the initial stroke victims are at risk of stroke recurrence within 5 years. Therefore, the preventing recurrence is an important strategy for decreasing the death rate of this severe illness, which is stroke. So self-management intervention and self-management program among stroke patients could significantly improve their survival rate, level of independence, and also their death rate as well. Most self-management program or interventions for stroke have been developed, and most studies have been published within the last 7 year, as you see in the figure on the right side. Interestingly, in 2000, between 2014 and 2018, that is the highest number of the publication regarding the self-management program. So it is 18. So this phenomenon is plausibly linked to the enhanced perception of the importance of the incorporating patient along with the caregiver. This is important. So in attempt to address the illness and the importance of encouraging them to take the responsibility for their recovering to achieve the more satisfying outcome. However, unfortunately, a previous study also found that 86% of self-management intervention or program were conducted in high-income countries. This finding may indicate that in low middle-income country, the limit supply and the lack of the quality and progression of healthcare may result in adequate health consequence, which is prevent the invention and implementation of the self-management program. To support the patient with the stroke in low middle income countries, the previous literature suggests that provider-centered care is still mainly adopted instead of the patient-centered care that incorporates self-management. How about stroke self-management in Thailand? I would like to talk about this briefly. So self-management among stroke population in Thailand is still need to be improved. So there is a shortage of study regarding stroke self-management in Thailand that should be further study optimized for the Thai population. A research study application of Thai and foreign empirical evidence to developing self-management methods for stroke patients show that registered nurse role should be include educating, which is educating stroke patient and family member, motivating, which is creating motivation and positive reinforcement, supporting means that gathering support from the patient and their family, counseling refer to counseling for the patient and their family, building necessary self-management skill, and lastly, establishing nurse-patient relationship. So that is previous literature's recommendation regarding the self-management in Thailand. The article also suggests that self-management program should be applied by stakeholders such as healthcare organization, administrators, and policy setters to develop a high quality procedure for stroke care and prevention in Thailand. So in conclusion, self-management appear to benefit stroke patient symptom management, improve their survival rate, level of independence, and death rate. Nurse-led self-management program could be effectively adopted in low-middle income countries, including Thailand. There is a shortage of research regarding stroke self-management in Thailand that should be further study optimized for Thai population. And my recommendation is that the feasibility and acceptability research of technology-based self-management intervention, such as telehealth, virtual reality, mobile health, or even machine learning in stroke population should be conducted. So, okay, I would like to spend a second to thank Shishanok and Lalipat from the Department of Medical Nursing, Faculty of Nursing, Mahidol University for helping elaborate this presentation. And thank you all for listening to my presentation.
Thank you very much, Subsan. He's a new generation of the Faculty of Nursing, Mahidol University. Thank you for your excellent presentation and sharing your research interest in stroke management in Thailand, especially. So right now, I would like to start the Q&A session and discussion. So do we have any questions right now? Okay, so if not yet, I would like to ask the questions, a couple of questions based on your presentation.
I think we have one. I'm sorry. I think we have one question from Shishinok in the chat. I don't know if you see that.
Okay. So she has mentioned about the telemedicine, right? The telemedicine that enhancing hypertension cell management. I'm not sure that she wants to ask a question, but I think Dr. Commodore Mensah, Thomas and Samuel, and even you, Subsan, you probably have any ideas or experiences to share about the telemedicine using to control blood pressure, right, and stroke management. Yeah.
Yes, I'm happy to chime in, and Susan can also, and others can chime in as well. So we know that in the past 2 years, there's been a rapid expansion or explosion in access to telemedicine because of the COVID-19 pandemic. And telemedicine or telehealth existed pre-COVID, but it wasn't really adopted and utilized effectively. So in the DINCREST study, which Samuel alluded to earlier, what we've tested is a nurse-led mobile health enhanced intervention that also includes a component of telehealth. So we actually started the study before the COVID-19 pandemic. We gave patients who were diagnosed with hypertension, we gave them a home blood pressure device. We also, if they did not have a smartphone, we gave them a smartphone. We gave them access to a mobile health application, a telemedicine application developed by Medtronic. And then the nurses were also trained in management of hypertension. And so the nurses were able to communicate directly with the patient. So there was that bi-directional communication. And so during the COVID-19 pandemic, and when there was actually a lockdown in Ghana, and patients were not able to be seen in person, we actually noted that our participants who already had the home blood pressure devices and already had that access to the nurses and the healthcare team, they were able to continue receiving care remotely. So I think that the simple answer is that telemedicine is a promising approach, but there are a number of things that have to happen for it to be widely implemented, right? So we had to purchase the smartphones for patients who did not have them. So when we think about interventions, we want to make sure that everyone has access to it. And so for those who did not have access to smartphones, we purchased them. But when you think about scaling up that intervention, it might be costly, right? And for healthcare workers, they also need training in terms of the mobile health application use, but that's also possible, but requires resources to do so. So Thomas and Samuel and Susan, I don't know if you have anything to add to that.
Yeah, can I talk about that? Actually, in my experience, I've worked for a telemedicine health service. So before I came here for my PhD, I also worked for a program called Bubble Health in Rwanda. And what they do is they provide telemedicine healthcare to people and actually work with health insurance. And it has opened doors and shown that telemedicine is feasible in Africa and completely feasible. And it's not only with people with smartphones, but also people with feature phones. And where you just dial in a code and the healthcare provider will call you. Instead of you having to travel to a health facility for 2 hours or longer to refill your prescription, you talk to a nurse or a doctor. And then they review your symptoms. And if you had a blood pressure machine at home, then you'll be able to measure your blood pressure and you tell them your blood pressure measurement. And then they could prescribe you a medication and you go pick them up from your nearby pharmacy without you necessarily having to go on the long queue all day to the health facility just to get a medication refill. So I just wanted to highlight that telemedicine is feasible even in lower middle income countries. And Rwanda has demonstrated that that's really possible.
Yeah, thank you very much, Samuel. Thomas, would you like to add anything?
Yes, so just to add up, there are a series of discussions ongoing at the national level to implement telemedicine. In fact, lessons from COVID-19 has taught us that there will be a time that patients will have to stay at home and receive the necessary care. So at the national level, there are a couple of discussions ongoing. And I'm sure by the end of this year or two, Ghana will probably be the first country to try that out. Yeah.
Yeah, thank you. And Subsan, I think you probably know better about in Thailand, because like in the previous webinars that we were talking also about the telemedicine, and we think that it's actually, even though it's feasible, but it's not really like feasible for everyone, for every area. So Subsan, would you like to share like the challenges or like your experience in intervention or anything about the management in Thailand? Especially the stroke management or using the telemedicine, please.
Okay, yeah. Firstly, I think I agree with Dr. Iwan and Samuel in terms of the accessibility of the telehealth. So in here, USA, conducting the research regarding the self-management in the hypertension African American population in USA, and we are using the telehealth. So I think how different between the US and in Thailand is that the feasibility and the accessibility, because not everyone in Thailand has the mobile phone and also even the internet to access. So that is the most challenge of the using the telehealth in Thailand. But I think in the future, as a researcher and healthcare professional, we will try our best to give an opportunity to every patient to access to the healthcare. So that is my great response. So
thank you very much. So for the next question from Dr. Sarindrat, she asked that like she would like to ask about machine learning, the ML. Would it be possible in your country to implement, and if how to be? I think someone like Thomas or someone else, right, that have mentioned about like using the machine learning, right? Is that clear for the question? Okay.
I think I did mention about machine learning. I'm sorry if Thomas and Samuel, you have something to say, or I can go over that.
Okay, probably is my fault. Sorry. But of course, like about the machine learning, right? But so the question is that, like, do you think that you would apply that in the sub-Saharan Africa also? I think because she mentioned about Ghana and Thailand, both countries.
You want to go first, Thomas and Samuel, or I can go first?
Yeah.
Okay. I can go first and talk about this. Of course, machine learning is about having this big amount of data, which is put in the model so that it can help to predict what will happen and which interventions are likely to be successful. That way we learn from the mistakes or learn from the experience to continuously improve. And this is something which we really need in sub-Saharan Africa. Unfortunately, it is not there yet. As Dr. Thomas has shown when he was presenting data, Sub-Saharan Africa is more poor on studies which explore cardiovascular management and the outcomes. Even where hypertension management and other cardiovascular diseases are being done, data collection and its use for continuous data, for continuous quality improvement is really poor. And this is something which is really promising and we would really recommend it. But not right now, it is something which is quite behind, but I would let other members of my team to chime in if needed.
Yeah.
Okay, yeah, I think, Sam, you said it all. I don't have much to add. And I think that with time, the continent is actually picking up with regards to data sensitivity. And we hope that in the next 2 years or 5, we'll be able to improve our data quality. Because when you come to Ghana, as I speak with you now, we have improved the NCD indicators. These were things we were not looking at. We were not discussing them previously. but we are doing them now, even though we are not there yet. But I'm sure in a couple of years, we should be able to implement some of these interventions.
Yes, I
Yeah, and
think
I'll
so.
just quickly add that, yeah, it seems like a promising approach, and I think it will take us a while to get there because majority of the health systems do not use electronic health records until we get to a place where there's greater uptake of EHRs. And when you think about more rural settings and how patient documentation is done, I think that would be a start, right, in terms of ensuring that in terms of data science and our data structures that we enhance the use of electronic health record systems to facilitate things like, machine learning.
Thank you very much. Subsan, would you like to add anything?
Yeah, I think what Dr. Ivan said is very important regarding the electronic medical record, because building machine learning model, we need a very organized electronic medical record. So last year, I have one publication regarding the feasibility of using machine learning to classify the severity of the cerebrovascular disease. And in the near future, after I graduate and back to Mahidol University, I think I will plan to do the research about the feasibility of using the electronic medical health record to build the machine learning model to in terms of using it to classify the stroke patient in Thailand as well. But let's see the information we have first and then plan further. So thank you so much.
Yeah, that's a very nice plan because ML or machine learning right now is, in this era, we have to use more technology for our research, right? Especially for the predictors, for predicting outcomes or designing interventions in the future. So I think Dr. Vimonrat, she raises her hand. Dr. Vimonrat, would you
Yes,
like
would like to on off speaker to share some idea about my research and my experience about stroke, because I have conduct research a lot of stroke management and about the stroke awareness in Thailand. So I have publication in this year about explore the influencing factor of ischemic stroke patient about medical adherence. So the first question is, I find that medical adherence is still the problem of Thai people. And also I think that in the middle and low income country. So I would like to ask your opinion. What are the idea to implement the AI or machine learning to improve medical adherence and also perceive susceptibility, severity, barrier, and self-efficacy that I find for my current research of with our master degree student, it still have the problem. This is the first question. And the second question is I have a 2 or 3 research about the brain exercise in the ischemic stroke in Thailand. And I would like you to sell to my idea, what are the digital or like a computer science or something else like a technology to enhance about the brain exercise in your countries and your experience, please. Thank you.
Thank you very much, Dr. Vimonrat. Okay. Also, Dr. Yvonne, she has sent the paper.
Yeah, I think,
Yeah.
yes, I think you were asking about interventions to improve medication adherence in low and middle income countries. I just want to clarify that I understood your question.
Okay, anyone would like to talk more about? Yeah, thank you.
Okay,
Thank you
yes.
very much. Yeah, so I
so
think
the article, yeah. So the article really illustrates a number of strategies that have been used in low and middle income countries. It was led by Bumi Ogunbe, who just recently graduated from our PhD program. And in that article, she outlined a number of interventions, some that use technology such as mobile phones, engaging community health workers to assess and address adherence, sending SMS reminders, right? So we talked about the fact that some patients have phones, but they don't have smartphones. So there have been some interventions that use SMS messages to remind people to take their medications. But there are also things that clinicians and providers can do to enhance adherence, right? We know that single pill combination therapy, that's one of the ways to enhance adherence, and also changing from multiple dosing to single dosing. So rather than a patient taking a medication 2 times a day, maybe switching to once a day, right? So that's one of the things, or a few of the things that clinicians can also do to improve adherence. And also, I would say, meeting people where they are. Samuel talked about the fact that in some studies, patients have to travel 2 hours, 6 hours for a condition that's a silent killer, right? So they can't tell if their blood pressure is elevated. If we are to provide better access to medications within their communities, right, and make it more convenient for them to access the medications. And Samuel noted that in one of the studies, living within 30 minutes of the health facility was associated with a higher likelihood of blood pressure control and adherence. So those are a few interventions I would highlight.
Yeah,
Thank you
that's
so
great.
much.
Ajahn Vimalrat. Thank you very much. So please feel free to raise your hands as well. So we welcome anyone to ask questions. So I think you have mentioned something about a physician-related barrier in clinical inertia, right? I think Thomas, right, has mentioned this, and I would like to ask a question about this. So you have mentioned about physicians, they are using the soft reasons, right, to avoid treatment for hypertension. Can you please give some examples of the soft reasons?
Okay, so I think I did mention a few. And some of the reason being that, okay, so today there are a lot of patients waiting outside. Can we do this next month? Some of the reasons could be that today we don't have enough drugs. Can we do this next month? Some of them could be that today have a meeting. Can we, so you try to sort of dodge you putting further strains on the patient. Because sometimes you realize that the patient standing before you, if she's supposed to buy extra drugs, and remember, if you want to improve adherence, sometimes you may want to move from just a single therapy to, a double. And sometimes realize that these patients cannot afford. So what do? You try to find other reasons to, skip the stress. So these are some of the reasons that some of the physicians give. And that's why we said we need to look at it holistically from a system approach. Let's make sure drugs are available. Let's make sure we are interacting with them adequately. Let's make sure we are communicating with them based on their cultural context. Yeah, thank you.
Okay, see, thank you very much. So it's very interesting because I think in Thailand for the hypertensive drugs is that free, right? Mostly, yeah, because it's like the common disease, like, and the health insurance would cover for the medicines. So I think, wow, in sub-Saharan Africa, it's still a challenge, right? Challenging to provide care for the hypertensive patients. Okay. Do we have any question coming? Okay, from Din Yajai. So she's asking a question about, could one of you please share us your success story in caring for an older patient with hypertension in Ghana or I think Sudan or Nigeria, right? Or even in Thailand, I think. Thank you. Thank you very much, Din Yajai.
Okay, so I think I'll go for this one. And I'm happy to say that some of the most satisfying moments is when you treat a patient, then they come back to you the next day and they tell you, oh, your drug actually worked. I was able to sleep last night. And that sort of motivates you to do more. And you know, when you are dealing with old patients, sometimes they ask a couple of questions, but you need to be patient with them and address their concerns. And sometimes too, they forget easily. You tell them this, in the next minute they've forgotten. They will come back to the consulting room. And what I've learned in my practice is the fact that when one patient becomes satisfied with what you've done for them, they will tell everybody. And that is a strong factor I've always told my healthcare professionals, especially those who work within community settings where they are related, and so the next patient knows the next one in the next queue, and so on and so forth. If you're able to deliver quality care, they will advertise your facility to other patients. These are some of the experiences, but sometimes too, it gets sad. I have had the opportunity to, nurse a couple. When I returned from school, they were there, and one of them has, had complications. Within a couple of minutes, she was dead. So the husband came to me crying, and I was very emotionally down. After a couple of weeks, the husband also died. So sometimes I think about it from also a family perspective, that we need to treat them as a family and not as an individual. When you touch on, family support at home, you also need to invite some of the family members in. And it is something that Ghana is trying to take up, which is caregiver support. We are not only focusing on the patient, but we are focusing on the relatives. And at the end of every month, every hypertension patient will come to the clinic with the relatives. We will screen them for their blood pressure. We check their blood sugar level to sort of also make sure that the one taking care of the sick doesn't develop complications or doesn't develop conditions and die and leave the one she's actually taking care of. Because that also happens a lot. You have a patient who's so stressed, she's taking care of a sick patient, and the next moment you hear the caregiver is dead and the patient is alive. Thank you.
That's an excellent story. Thank you, Thomas, for sharing. Yeah.
Can I also talk about a success story, but on the health system level? As I talked about recently, I was in Ghana, and I was actually surprised by one practice which I saw at some health facilities. Actually, we were saying that the screening for hypertension is a problem because people do not get contact with the health system to get screened. And the opportunity to do and go in the community and do mass screening for hypertension are scarce in sub-Saharan Africa. So there are some health facilities which have initiated the service called Wellness Clinic in Ghana. And what Wellness Clinic does is everybody who comes to the health facility could potentially go and sit in that booth, get their blood pressure measured, get their weight taken, be told about the risk and how they're sending in terms of blood pressure. And when actually they're found to have hypertension, they're immediately referred to the hypertension clinic so that they can be initiated on treatment if needed. And that I have seen it, and when they do that, it's free of charge. They don't charge you anything. And you went there not with the purpose of getting hypertension care, you were just accompanying a family member and you were just passing by, or you were bringing food to a patient who was sick at the health facility. But then you got an opportunity to have blood pressure measured. Of course, some people would argue, but this is not a small number of people who go to the health facility. But again, that is another opportunity because you just came to the health facility and then you went home with a healthcare service, which you did not have to pay to, but it has potential to save your life. So I have to share that success story and actually recommend this for other countries as well to try this approach. It's really good.
Thank you very much for sharing, Samuel. Dr. Yvonne and Sipsan, would you like to share your stories?
Okay.
Really?
I'm sorry.
Nothing to add. Sorry. I have nothing else to add. I think Thomas and Samuel have provided, great examples of the realities of improving blood pressure control. So, Sipsan, do you have one to share?
Yeah, I think I have a little story to share. Right now, I'm conducting the research with my professor. We are using the self-management program to improve the medication adherence in African American population who are living with the hypertension. And one component of that intervention is using the mobile application to improve their medication adherence. And can I call this a successful story? I'm not sure, but I have an value opportunity to approach the patient and I teach him how to install. I think he's almost 90 years old, you know. I help him to install the application in his mobile. And once he successfully installed and I demonstrate how when you get the medication adherence reminder, you need to do this, this, this. And after he did that, I think he has a very, proud of himself, and that is can improve his self-esteem. And when he say, "Oh, thank you so much, I will do this to improve myself." So that is I feel like, okay, I can do something with, I can help people. So I don't know, this is successful story or not, but yeah, happy to share.
Yeah, that's a very nice story, Subsan. Yeah, it's like your inspiration that you would like to take care of the patients, right? And we are running out of time. So, but the last question, it sounds like a very interesting question. So I would like to ask the last question to you from Shala. Okay, are there any specific methodologies or steps followed for patient lifestyle changes that also help adherence to the medication? Yeah. So this after, I think the question is that like after you provide some medication or intervention, like how would you follow them, like lifestyle changes? Yeah.
I think I can go over first and then maybe if. So yeah, I think as far as I know, the appropriate approach to follow the patients or people who are living with stroke or hypertension medication adherence in long term is that maybe longitudinal study would be the most recent methodology for that, because for example, the study I'm conducting right now, we are follow the patient at baseline 3 months, 6 months, and 9 months. So we have a very long period of time to follow them so that we can see the trajectory of their medication adherence improvement. So that is one thing that come up now. So I'm not sure Dr. Iwan and others have something to add.
Yep. So in the Indochina study, which was conducted in Kumasi, Ghana, I mentioned that the intervention was a multi-level intervention. So it was nurse-led, it was mobile health enhanced. But in terms of the intervention that was led by the nurses, one of the things the nurses stressed was the importance of lifestyle changes, right? So they also stressed the importance of medication adherence, but they talked about limiting intake of sodium, right? Being physically active. We are still analyzing the data, so we can't tell yet if really this multi-level intervention improved blood pressure control. And with a multi-level intervention too, the challenge is really understanding which component of the intervention accounted for the improvement in blood pressure control. But consistently, studies have shown that interventions that address the multiple determinants of blood pressure control are more effective than those that address just one level, whether it's a patient level issue or provider level issue.
Thank you very much. So in the future, I hope that you can share with us for your studies results. That would be very nice. Yeah, thank you. So now I think we are coming to the end of our 7th webinar, and I would like to say thank you to all speakers for joining us and all the audiences from Thailand, from the Southeast Asia, and from the US that you woke up in the morning to join us. And I would like to say that please join us for the next webinar, the 8th webinar that would be in August. The topic would be the update guidelines of diabetes care and management. Okay, so I hope you have a good evening and have a great day and see you later. Bye-bye.
Okay, have a good one. Bye-bye.
Thank you so much for having us.
Thank you.
Bye. Bye.